Yes, sir. Like there is only used in the fiscal mechanisms and the prices, not in the proximal sector, which we should not, indication wise, we are not supposed to do in the proximal sector. And like, because of that, when you see exactly in the case, probably not in the case, the decomposition will be and then the decomposition. Very good. But the decomposition, they already decompensated for surface. Like it was the anger. This call of private was not acceptable. Okay, so low and specified. I've never seen one low and specified positive. They generally never. So no different. But I don't know why we have missed. Still, we keep on using it. So we need more. We have been quite often and things like that. Well, I've never seen one positive. As long as you get positive, nothing comes out. But if you see global session, must be learned starting with last time I wanted to cross up what the very good last time the recipient I would rather say go ahead without knowing answer. Okay, thank you very much. So we move on to the next session. I first call the moderator of Srikanth Mula. He is a consultant surgeon in liver transplant in HPB. You can call the speakers. So, you can retain your seat. And I invite the other panelists, Dr. Nivas Chandrasekhar, Senior Consultant in Liver Transplant Anesthesia and Critical Care. Dr. KRB, he's a Director of the Short and Long Transplant Treatment. Welcome, sir. Dr. Tyagarajan. I think sir needs one introduction. Sir, please. Over to you, sir. Wait one second. Wait a second. CABG and LDLT. This is a panel discussion. So this is more of a interactive session than more of questions than any limited. So I welcome other panelists, Dr. Gyan Rajana, Chief Clinical Diagnosis, and Dr. Suresh Rao, Co-Director of Heart and Liver Transplant, Dr. Work, and Dr. Nivara, Senior Transplant, Liver and Transplant. So, your liver transplant relation is readily as we discussed, because nature summary events liver transplant can lead to severe comorbidities and mortality during the surgery and post-op. These days, with the increasing surgical expertise and anesthesia care, we are operating older people and comorbid patients. So all these patients high risk of this coronary disease. So for these patients, if stanting is not possible, then CABG is the next option. So isolated CABG, if we take a patient with isolated CABG without liver transplant, then they might have the high risk of coagulopathy, sepsis, and most operative liver decompensation and liver failure, ultimately mortality. So isolated CABG in severely decompensated patient is very high risk. And if you do alone LD without CABG in high risk cardiovascular patients without any prior stenting or anything, that may lead to severe adverse cardiovascular events. So we take up on a major procedure which is combined liver transplant and CABG in this new setting. So how do we do it? So for that I would first like to ask Dr. Taylor. So when you decide that patient undergoing liver transplant evaluation and found out they have critical vessel disease, whether we prefer isolated CABG or liver, how will we decide?
Basically, any liver failure patient, even child B or child C, they would definitely decompensate after isolated CABG. The chances of any post-operative liver failure is more than 60%. Any major surgery in the body. So both are important outcomes. So you cannot do isolated CABG, the risk is quite high. In child safe, very calculated patients can do, but still it's risky. I don't know whether the correct team will take child safe or child B and C. There are high risks of liver failure. So, any guy with child B and child C, I would go for a combined procedure. Or I'll ask the cardiologist first whether they can intervene and do the stenting. I would prefer a stenting rather than combined procedure. Combined procedure are very rare and very highly complex. And results, that's what we have 100% results, but that's not routine. We will go for stenting and followed by transplant. If the cardiologist is not able to stent, then only we will take off CABG with transplant.
Yeah, so with LD and CABG patients, to take an isolated procedure for CABG, every chance there they might become website. LD can think if a abdominal specific is less than that, because your eligibility is less than that, then we will think of isolated CABG. That's true, the chance of becomes the more than.
So I think Gary can as well answer this. How comfortable are you taking a cirrhotic patient for isolated CABG?
It is not easy because the CABG part, in fact, this question is more relevant in our current practice of transplants because, in fact, we were the first in the world to publish this. A significant number of our heart transplant recipients are actually cardiac disease with multiple previous symptoms or pulmonary disease. So what we found was those with very high right atrial pressure, long-standing blood pressure. Some of them have a score of more than 20. So when we do an isolated heart transplant, we go to the instead of replacing the whole heart. So CABG with poor liver function actually is catastrophic. By and large, we try to avoid it. But 10-15 years ago, when we were forced to do this, liver transplant was not very commonly done. So it was hit and miss in terms of survival perceived exhibited targets.
Yeah, okay, sir. I will please refer for the common procedure what we assess with cardiac outcomes in this yearly patient especially.
Of course, the first is, as Dr. Mohan Mohan said, it's a positive example. So from a surgical point of view, we would like to know, look at the medical, including regional evolution abnormality. And does that correspond with the anatomical parameters of disease that we see on the NHLM? And number two is patients with liver disease can have pulmonary hypertension. Yeah, and pulmonary hypertension is a risk factor for CABG even otherwise. Because it can have important consequences in terms of vascular dysfunction. Today, we prefer to do any CABG off pump and off pump with pH. You have to be careful because when you live the heart, the office vital muscles, in the presence of pulmonary hypertension, the heart often does not tolerate. So in that case, we tend to check and we graph the OM further distribution because there is one more possibility the heart requires more infection. So we end up compromising a lot of things. So it's very important to know the degree of pulmonary hypertension. The third assessment we really like is the CME is being considered. I think it would be a good idea to actually image the content. It's not often done because we have two legs, so I would think that we have two long segments of surface vein. But one of them might be needed for you in case you have to extract investigation. Private results that we get. Nevertheless, sometimes the veins are very close, sometimes the veins have been stripped. Stripping is not so common in patients as I've seen in Western world very often. We have such bad veins that by the time they come to the veins that stripped are often too small incisions. So if you don't take proper history, you can pick up the whole thing and suddenly not able to find a vein. That can be embarrassing. And always image the radial artery because especially with younger patients, and India has the notorious statistic of premature atherosclerosis. So if you have a younger patient requiring multiple grafts, you may or may not want to do that memory for the immune suppression things. So it's a good idea to image and also always look at the graft. Yes. As part of the CABG work in any case, but not sure how many of you are able to have significant cardiac disease. But if that is there, it's nice to know because you need to plan a caravan and that is the CABG.
Thank you. So, sir, how does some of CABG better than one-pump SST? So, yeah, it's not a good reason. Changed. And also organ perfusion will be changed. So this all results in so many adverse effects. But the thing is being hepatic disease, which actually causes hepatic artery vasoconstriction. Hepatic blood flow is reduced. So this is that if you're doing the bypass in the post bypass period, if you do the serum transfer storage there very stays in the ring. So basically causes more cracking. And at least the article bypass will be more there will be issue hyperperfusion, hyperperfusion. This all results in various symptoms. And also hyperperfusion. It also has got increases the competition for time. So, typically is more risky. Very effective. One is by good study. It looked at almost 30 lakhs cases. And we found that all these is more risky. The last study last Last year, actually, making much difference in my now there is what study or study where that study they find difference in the so one of them is I think it is best so how in a experience and one of the sweet spot is development with the vaccine and it's not all as an economic we are just trying to understand each other. So it's like any guys using coffee machine also comes up. It comes out that corporate doesn't up. Between a line in a highest behavior. So this question of motion on our actually this is the volume screen and rate theory maybe. So I love the use of theory. That's what I can be the same in the evidence of disease regarding the plan and the level of the reverse flow. It is more true. The thing is the thing is regarding the and the coordination by this basically that's like what the simulation being there how saving the country there is because it's like coordination and the coordination that starts in the world. But coordination there will be a balance between the coordination practice and the natural practice. That is very important. So when there is a reduced coordination practice, happens to the structure, it's very like how there is food to happen. It's not monotone. What I make almost is expired. We have to order the use coming to the undiagnosed or basically the hepatic disease. So in the pre-operative period, usually we have a discussion with the hematologist and cardiac surgeons how to manage this patient because we have a risk. And coming to the anesthesia part, so infection usually go for the inhalation agents and Esmolin is the drug of choice. Mucil laxatives, we refer the bacterial water bacterial. And we have to know that the if there is hypotension, water is the drug of choice. And in the post of period, we have to look for the renal function, endocrine syndrome development. You can have the panic encephalopathy where you want the neurological function and then they have chances of infection. All of these things we should be close to. What is the surgical plan for CABG? Is it different from our patients who are treated with us? Apart from the usual workup, particularly make sure that I would be doing a Doppler ultrasound of the legs to make sure the quality of veins, especially if someone undergoing a liver transplant and immunosuppression. We would want to make an incision and find out the vein is not used for the vein.
very good question. Well, I'm not asking that. This is for she's not a good candidate for CVP delegates. And she's not a candidate for states. So what do you, so I suspect that can happen in people as well. Where if I end up requiring the wrong patch and it's not your and how never have you done it. Public issue is how we should Congress talking about content. Education criteria is more similar. I think it's 10% of market transaction. But I like this on the this service also actually. So our latest year is certain humanities for body. This is transport is state. So sequential like first theory and then follow one is like you get a more favorable influence and transfer rate. So like one of the US is and I see these very good ratings. The first but most of the patients will have moderate to severe status along with the fluid patient. So sometimes very good actuation. Put together studies and person able to decrease in venous. So after dealing with all the ICDs and revascularized disease segment, you get a better. Apart from that, you see with all the October, starfish, doing one and a half hours, hardest to lift her and to start. The hemodynamics is stable throughout that procedure. Proceeding with not much cross-match and other things. Moving on to the next commonly discussed concepts of anticoagulation is bleeding. So what we do is we discuss the average complete closure theory. We do one external we suggest one of the whole procedure is kind of one surgery CABG transplantation system of the flow. We will reopen CME specific infection in the pentagonal or pleural space. Would watch you. Regarding anticoagulation, I think like the previous point which actually was suggested. Liver is not always just the bleeding. Actually, it's imbalance between alternate balance between coagulant and anticoagulant. If you see decreased blood level, it's not just you won't see them bleeding all the time. They tend to have a lower clotting factor also. All those also are decreased. So they are decreased but balanced coagulant and anticoagulant factor, which are different issues. So when you
see a room that you don't have to start giving we give during the transplantation procedures. We target basically 1.5 times on the baseline value. So we don't mind patient getting recognized during CABG. We like to continue that recognizing. Apart from that, other hemodynamic yield changes or procedures during liver specific like then there is a disease liver that will be cause something of major venous vessels like LDC cause something happens. Which decreases the venous return preload. This will combine most of the specialists receive pretty they will have exercises weekly. So they will be put on bit of blockers, bit of medical, all the things will have an afterward effect. And some degree of myocardial strengthening of myocardial depression will be there. Of course, that will be delivered in other contributing factors like so these surgical events like cross-clamping, portable along with the blockers, usually with without an internal pressing, if it's even more zealously used to address the HRS component, they cause after that effect, the parents supplies and cardiac approach are often. So what tends to happen is like when they cross clamp or when they really get globulus, the compensatory kicking of cardiac arrest happen. So these patients tend to develop the risk of severe stress cardiomyopathy, repercussion, lead to all those things are there. So when we see such patients during liver mobility experiences, you type like iron rotation, all of these things, contractility, everything is taken care of. So in a some CABG, we actually tend to get more favorable animals. Very low development recipient with all the ingredients, all the chickens. So it's better to manage the vascularization without ICs. As soon as the liver such what we do differently from you. It's all comments.
First of all, it's a very complex procedure. It's not very easy. We need an excellent team of cardiologists, cardiothoracic surgeons, critical care anesthetists, and your intensivists and the transplant surgeons. We need a perfect coordination. First, they do the CABG, and the coordination part is taken care of by our anesthetists and the critical care specialists. We are not worried about the bleeding. We are worried about the clotting. So, liver disease is profusely bleeds. When they have paralyzed and reverse, there is a very high risk of bleeding. That's why these recipient surgeries has to be done by the surgeon who has got the highest experience in liver transplant. This should not be done by providers or new transplant surgeons. So many people are afraid. You need an excellent hemostasis for this recipient hepatitis, recipient removal of liver, which is very highly risky, they can bleed. So if you have an excellent surgical technique in the form of harmonics and particular hemostasis, and the early motor control, and you can do a pretty good job. And the important thing is your family. So normally we prefer to do the total family, but when you have no heart, so we try to do that side family where they leave the partially with our fluid. So these are the two major things, and most importantly, we don't allow the surgeons to close after they did it. Once we left the liver transplant, we again antibiotic, have to check the chest again, so that the hemostasis is perfect, then only we close, because a lot of times we are seeing after we take the liver leaks from the chest. So these are the three important things in a combined procedure I would take care of. And the recovery is pretty much standard, not much difference. And I think all the sections are done extremely well. The first one is 4 years old. Other two are doing well. One guy underwent both LDT. Was first.
So, so what is the booster rate because of speedway agent? So, the same point I think is parallel as well. Okay, we prefer patient who is leading like compared to a patient who is operating because if the training is good, if not much training, people are stable because to have some of the top and last so topic also I discussed about the platelet matters. It's one platelet, yes, on the same platelet both the ABs are we have operating with let's say even the low dose let's say like influence with oxygen. Because like even if there's a history from transfuse, you can go on very slow walls. So what they get is very messy and whatever influence you have to come to the molecular method post. So it doesn't help much. So it always keep to favor a little bit down until like the state also surgical is comfortable with the rhinoceros training. Next thing statins. Yes, the assessment critical failures starting starting the early stage. Of course, there is a 0.3% chance of elevated liver enzyme because getting not all patients benefit the decrease in cirrhosis or really but long term, yeah, as a recurable at the same time, if the patient has an illness, we can even change the reduce the doses, or we can do changes for other form of statin, even to alternate care regimens, even temporarily without the restart at that so, the answer is yes, I really prefer this single like aspirin combined with let's say it is now okay. Once enzymes are established, so that they able to that. So, password is must be a good and one patient is 4 years old. And recommends Okay, so we'll now take a break for the, we can have coffee and after the inauguration, we meet at probably 10:30. Okay. Thank you.
Thank you.
Audio. அதுதான் check
có giáo phần chương trình giáo phần
6 மணி ஆகும் வீட்டுக்கு
ம்
வீட்டுல இல்லையா?
தெரியலையா அது தெரியல.
இல்ல நீங்க சொன்னதே வந்து பார்த்தா 11 மணி தான் சொன்னாங்க. நான் எனக்கு இன்னொரு ஆர்டர் இருக்கு. அதை வச்சுட்டு போய்
எனக்கு தெரியாது. யார் சொல்லுச்சு?
அவங்களுக்கு தெரியாது சொல்லிருக்காங்க. உங்களுக்கு தான் idea
மைக் சார்ஜ் போடுங்க. செக் பண்ணணும். ஒரே நிமிஷம் check பண்ணிட்டு. வெளியே போக முடியும் வெளியே போக முடியும் வெளியே போயிட்டு வந்துடலாம். மெயின்டெனன்ஸ் தான் ஆகும். அவங்க வச்சுருக்காங்க. Yeah, yes. Yeah, right. இன்னும் சிம்ஸ்ல ஸ்டெப்ஸ்லாம் பார்த்தீங்கன்னா எஸ் 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 சிம்ஸ்ல பாருங்க. ஆயிரத்தி சிம்ஸ் ஸ்டெப்ஸ் சொல்றா. ஆஹா. எது இது ஹலோ. இருக்கா அப்படின்னா என்ன ஆச்சுன்னா, நம்ம தமிழ்மாறன் வந்து அட்மினிஸ்ட்ரேஷன் லாகின் பண்ணி ஒரு இனோவேஷன் இன்ஸ்டால் பண்ணிருக்காப்புல. யூசர் நேம் தெரியாம அப்படியே விட்டு போயிட்டாரு. அப்ப எல்லாரும் என்னென்ன யூசர் நேம் சொல்லிட்டு அவங்க யூசர் நேம் லாகின் பண்ணி விட்டுருக்காங்க. ம். ம். யாருமே இல்லையா இப்போ? Yes, sir. நீ ஈவெண்ட்டுக்கு போறன்னு யார் இருக்கா? ஏன் யார் யார் இருக்கா? எல்லாம் போயிட்டாங்களா அதுல? அது இல்லடா. நம்ம டீம்ல யாரு இருக்கா? நான் தான். ஆமா. ம். கேக்குறேன். ஏன்னா ஒன்றும் புரியல. கேமரா வேணா ஆஃப் பண்ணான்னு பாக்குறீங்களா? புரியல. புரியல.
liver transplant to liver transplant.
Timer on. Hang on. What is that makes you?
So I will invite the speaker, Dr. Sudaraju, chief of the multidisciplinary ICU and the group of hospitals. He will be talking on management of pediatric unit. I will be the chairperson for expert comments, Dr. Kulkarni. He is a senior consultant in liver transplant and specialty at Apollo Hospitals, and Dr. Bala, who is chief of emergency medicine in India. Thank you. I think given that to talk about mechanics, so really very important topic for us. And the next 10 minutes is going to probably go through on what is the wrong with the brain and person, what are the changes that are what are the changes that we do, and what would be our targets, what are the things that we get, what are the things that we aim for, and how do we do it? The role of visualize for so to start with the most important changes that happens in the body of a person who's brain scanned. Number one, there's a kind of service. So categories and then environment, political norms, and all this there is a huge. There is a significant and America for everybody. And as a result, high blood pressure, tachycardia, and all this can lead to the severe dysfunction of the heart. What can happen because of this? There can be a myocardial dysfunction, which can potentially of the region of the edema. We call it neurodegenerative. So the small heart of the brain is not functioning adequately. And as a result, there can also be an organ dysfunction that proportion to the other organs, multiple functions. And then there is this on the other extreme failure, the economic dysregulation can potentially lead to hypotension on one side because of the diaphragmatic surge we're talking about high blood pressure or tachycardia and all that, and the other side we cannot see a hypotension which is hypertension. This again is called confusion, and you can have cardiovascular dysfunction. It can also lead to hypothermia and temperature loss. And then there is a problem with the endocrine system. We talk about high blood pressures, low blood pressures, and there is an endocrine problem. Brain to gain the organs control every single cell in the body, but the brain is not constant. So there can be hypothalamic pituitary adrenal axis dysfunction, dysfunction. And this can lead to a wide array of problems from diabetes and to problems with thyroid hormone, which potentially affects your other organ dysfunction. It can lead to an insulin deficiency. Sometimes it can have hyperglycemia as well. So it can be a degradation. What is important is we have to monitor for endocrine dysfunction. Lastly, you can either because of the brain stem or because of the primary crop, usually there is a brain stem there. There can be a severe inflammatory response. Inflammatory response means cytokines, all the inflammatory products which can aid potentially in actual. This is like any disease, like any other syndrome, you deal with the patient with septic shock, you look for problems, give septic shock, you deal with the problem, the patient will further, the city liver failure is a separate step, we want to understand it, just look, you have to look for multiple things, and have to take communicate. But when from the physiology, other things that we potentially want to look at as main objective, we try to do, we want to optimize the heart, all the parameters here, we want to optimize the parameters, we want to look at electronic, we want to look at temperature control, we want to look at fluid balance, electronic balance. There are certain hormones which you have manually support as per most of the recommendations, as per the areas that follow our trade. And lastly, there is nothing to say. Now, the objective is to try to at least here the objective is not to say nothing from that. Because the only what the patient has very affected. The objective is to restore the potentially transplanted organs, restore the function that much as possible, so that the recipient has the least number, the least level, and maximize the function of these organs. One of the protocols, the Wills protocol, is being recommended by many of the transplant associations, so especially our also that CABG. Just to give you an idea of how we can go, we have to go on a protocol. It's actually called registration, I is called infusion, basically you're trying to manage the fluid. P is called pumping, basically heart function, and the other P is called pharmacological therapy. It might be anything from pharmacological, and lastly, S is called specific organ therapy. They are your patients. Now, how about that? There are some of the targets that we want to map actually do that. One is the blood pressure. I mean, so I have 60 to 55. Sometimes it's because of blood pressure over. So usually it's not severe of that, of course. So that you have to do it. If you patient is already good, it's supposed to target concept, the education factor. So it's I can introduce then fluid management. Of course, is very, very important. The idea of fluid is granules. Some centers do some scholars, but then it has to be used with caution. Label can be used, stars can be used, but they have their own products. Language, this is a solid solution. Advanced is not always required, but most of the patients who are breaking, they are already on ventilator. And they already have a centralized they put this monitoring, and we can also minimal mandatory monitoring along with the basic monitoring using the things. But there are other instances where they end up monitoring the cardiac because the basic standard, but it's not mandatory requirement. The last class of therapy would have been introduced for various reasons for the basic monitoring, and we have low pressure. Then moving on to the activity. So we saw the important. The third. Ventilation directly leads to carbon dioxide. So that's the degree required to be at least which is what you all have. And that was required to manage the population. And then you have ventilation patients not necessarily the last but the last is the form of energy for your oxygen and the proposal of exit or carbon dioxide portion. So it's very important to maintain proper oxygen ventilation by maintaining the next thing for oxygenation course, and then saturation of 95% is required. And when we go to pH ratios and we go 300 pH ratios for which we would gently reflect, that will be those ones which are being before. And then minimize or ventilate reduce. So minimize the ventilating pressures. So that we have certain parameters called lateral pressure and and regular numbers. If you run this deep important, it's very important that you keep your lungs open. Certain amount of ventilating pressures and there can be instances where bronchoscopy might be required to be transplanted clearly. Some of the hormones which are strongly recommended by the various transplant agents for those patients who are very extended. Number one is the present or present. Again, because of the HPA access dysfunction, there can be diabetic sensitivity This is the reason for the replacement of desmoid or vasoconstriction. Very, very important. The same as I would also want to talk about hyponatremia. Those patients, especially those ones who have a chronic pregnancy or some sort of a neurological problem, before the medicine the excessively choosing sodium levels. So we had 3% high, the need for reasonably high target sodium levels, somewhere close to 150. But unfortunately, this patient becomes brain dead, and the sodium itself can start affecting the other organ, especially the kidney and the liver. So it's very, very important that we have the sodium unchecked. If we think this patient is brain dead, then we want to look at the liver. We have to maintain the sodium levels. What we think is that you might be the donor liver transplantation. The liver is going to be transplanted and protect the contents of the liver. And then steroids. Prednisone is the most commonly recommended steroids that as a leading for better, but it's something which has to be looked into. And these are making steroids very, very important that we can sugar level. And then insulin infusion almost always be required to know from patients either because of steroids or probably promote inflammatory response. And lastly, other hormones. Those managed hormone we said complicated in 2023, they said that they are probably not making a difference. Whether hormones can have potential side effects, it can cause tachycardia, it can cause cardiac dysfunction, and it was also proven that whether hormone was not improving the status of the transplanted organs, especially the so for that reason, we just started moving away from many of the recommendations. So many recommendations are removed thyroid altogether. But in instances where we still have to think about thyroid, one is that if the patient is already high thyroid, the second that there is also thyroid. Temperature balance very, very important that we maintain normal temperature in 100 degrees. And then electrolyte balance most commonly administered for micronutremia, hypokalemia, hyperkalemia, and magnesia. Now these are the three important electrolytes if you want to monitor very closely. Many of these patients, for some reason, they have to put either being on some sort of an acid reagent disturbance, usually metabolic acidophilus. Very important that we try to keep them natural. Natural targets median amount of development study. These are acceptable range. These are not target something to understand. Again, for kidney, if you know, 1 per kilogram, and the oxygen around greater than 95. And the blood sugar is very, very important, 120, 180. Generally around 10, but a minimum of 7 is required. Again, normal temperatures, normal electrolyte, and maybe and lastly, infection control is very, very important because this is something mandatory. In the post-operative period, the recipient has to close up immunosuppression. So the infection control has to start from the donor as well. So as comprehensive set of cultures, blood cultures, urine culture, and bacterial cultures must be center. And many times these patients are ventilators lost with the ventilator. It's not to be granted intraoperative and in the post plant period as well. And whatever procedure you do has to be done in that personally recently to be granted or other infections. There's again no specific treatment modalities which is recommended. I'm not going to the details of it because they quite allowed it beyond the scope. But then what people want to do is look at the organs which are biased and try to ensure that these organs are preserved at optimal level. And this way, has to be
ஆமா
anticoagulants were being used for the non-chronic body, and those are very fun. The last means dedicated emergency is organ preserving CPR. Many times the patient is particularly trained and we need the organs to be retrieved, and that period the patient's might have a cardiac arrest or a critical situation. This is where you can do organ preserving CPR, which is very, very important. This is not a regular CPR, you're not trying to save your life here, right? You're only trying to do the CPR to preserve the organs as much as possible so that the recipient will benefit. The CPR is not different, but what's different is always important that the family is informed that when we are doing this for organ preservation and not for saving the life, do it with the consent of the child. Otherwise, it's not. Thank you so much.
So the then the one for the center line. So we have to take them to develop assets that are you right. Another thing is on the whole makers the related was the so when you started marketing, I was snowball variation and music was that they can interest and treat and do a good one for it. And as you said, I have also had the latter of things. Even if necessarily you have to give up that, I don't think many patients learn that. Or the ones even friendly here, we have to donors from silver. Recognitions to donors. The diameter of the kind of rackets is going up. That's where this you have to give that at least maintain eight or over eight minor groups have racket levels going up. Another important thing, depending on the area situation in the Thomas is quite delicate balance. Potassium levels. So we have to keep that in the another important thing, when you one of the computers with that kind of examples. The way we say, all of us will say that there are side effects to blood records. Nothing but they are changing the high commodity PKA to get hypertension and within this way of change. So what we do in our distribution is we use the backup of this so that we have the commodity company the energy active. When the is getting full, you start another and we back up and do it. If you do this simple things, many organs you can focus about. Agree. When it comes to transfusion, you can have to be a approach. One thing that generally observed people is the development of patient associated reaction. Very low. That's where I see that the English go around the thing. We can they are possible. Then you need to night. But then the transfers at that point, and then take the transplant available. You would probably take a guided approach where you don't want to ruin any of the organs where they will get one PRPC going into the plant. I think it's a guided approach. You become case by case. Especially for long time patients. Even culture positive donors, we can take a recorded things and cultures have come 20 years. Infection is something which I know that one topic and one product is allowed with 900 it is not absolute contraindication as long as the patient is of appropriate antibiotics and septic shock is not the reason for the antibiotic requirement. The patients can bone inflammation. And the crosstalk which happens between the initial treatment and then the transplant, the so that the antibiotics are not clear in the both of the But this is specific set of infections which can relate to doses where the transplant is really not being available. But most of the other hospital acquired infections it can be and the patients are eligible for the patient. Many questions from the audience.
feel free to comment. Thank you very much. Thank you.
So your liver supports nearly 90% of your metabolic stuff. And obviously hundreds of things are going on. And obviously you can't I can't go through all these things in next 10 minutes. So I'm just going to give some so the, what comes um, liver ac- so And all
fluid disease needs a transplant. So just for cosmetic purpose, because of huge liver, they will be offering transplant. But if they satisfy these conditions, it will go to transplant. Second problem is malignancy in metabolic disease. There are few conditions where you have malignancy, like ischemia, glycogen, EFIP. I think in others we use a lot of criteria, Pilar criteria, scale criteria, other criteria. But in children, if you have a metabolic underlying problem, you should use this criteria. If it is only liver, I still go to
go ahead.
maybe because the main issue, the trigger for malignancy is the underlying metabolic problem.
It's quite common in India. It is the uh, uh,
There are several things now that we can follow. But I want to strike really the sense that it is not limited to your liver. It is present in your GI tract, it's in kidneys. The problem after transplanting is PMIC type 1 is diarrhea and diarrhea. It's children because that intestine has never used to. When the new liver is put in, the new liver secretes a lot of bile, and the intestine can't tolerate the hence diarrhea. I don't think so. We started doing this total internal biliary diversions. Or even after this is one side after 5 years because the child had a fatty liver, developed fatty liver, and something like this. You can see the progression of fatty liver. This is 5 years. And at this point, we did the total internal diversion, and you can see the fat has completely disappeared. So this is quite recommended for PFIC. Then comes Alagard syndrome. This is an autosomal dominant condition. So one of your donor has the problem. Do we really need to do genetics on the donor? Not essential. I mean, when we need to do the screening, sometimes we do and cannot to make sure the pilots are fine. They don't have cardiac problem. So as long as the cholesterol is fine, and I think we can take them. We don't have to hold with genetics on the donor. If they are fit enough, we can go ahead and take them as a donor. And these children can have severe pulmonary stenosis and high light operations, which is an absolute contraindication for a transplant. So most of them would require a right heart study to look at the right heart pressures before taking them for a transplant. Again, metabolic liver disease, you can have neurological involvement. For example, urea like the defect, labels are defect. When somebody is neurologically damaged and you take them for a transplant, I think that's quite a difficult question. How to judge that? How severe is severe? But overall, I think we say they have a reasonable function. If they don't have a recurrent seizures, they don't have a fixed and fracture, and they're able to make sure good eye contact. It's not a bad idea to offer them. But again, with metabolic disease, you can have cardiac involvement, like uric acidity, they can have urinary. Minor cardiomyopathy sometimes gets better with transplant, but moderate to severe cardiomyopathy, then you shouldn't offer transplant. Primary hyperoxaluria, they can have low ejection fraction because of the oxalate acidity to the muscles. So usually anything less than 40, we don't offer transplant. We put them on hydroxyl dialysis to improve the ejection fraction before that 40, and then offer a transplant. Primary hyperoxaluria. Whether we can, one of the siblings has combined kidney liver disease, whether the other sibling will need to really liver and transplant. The answer is no, unless they have stage 3 kidney disease. Even within the family, the disease progression might be different. One side might progress quite fast, the other person progression might take 20 years, 30 years, 40 years. So unless they go to stage 3, we shouldn't be offering PFP transplant in national. I think this is an area of argument
Because
sometimes there is no answer and there is no guidance. But in our hospital policies, we try to curate them for 4 months and go into even for isolated person disease, we still go ahead with the transplant. Mitochondrial disease, again, an issue. Small baby, 3-month-old baby, we don't know whether to transplant, how to transplant. So we need to have a bit of threshold because we don't want to transplant a child after 1 year before the child is lying 1 year having seizures. So we try to assess the neurology as much as possible, like whether they have a leg control, or they have a good hypotonia, whether they have seizures or not, we check the visual VEP, the hearing, and if the circuits or your neurointegral circuits are fine, we conclude the transplant. Finally, a couple of slides. There are 2 cars here. And you can see one damaged car and one that is nice car. But if you're going to say the damaged car can run very well, and the nice car can be improper work. So it is same thing for the genetic disease. You can have a genotype. The genetic report can say somebody has these genes and things, but phenotypic manifestation might not be there. Somebody can have a phenotypic manifestation unprotected, but not expecting. So there is a wide variation, and I think certain conditions which we said will be offering transplant, like blood glucose control, which is the process of the different. But I think we should start putting patients independently and do the child 11-year-olds and those that have special developmental grounds to have liver disease. They typically put 1 year bigger. After transplant 3 years, I just think. So I think
we might need to sort of take a call on taking providing transplant for these children, and obviously we need to have a good multidisciplinary team to do it, and careful case selection is essential. Thank you.
One more thing, one respect is a type of for India. So that we have to because LDLT, we are going for LDLT, then we have to know who is the donor, and then I think we have to put the history of the donor. Of course, no one will be busy. I think we can take the parents as donors. They will have one of them will be a carrier. But I think we have shown that I think there is whatever disease we can still take them as a donor. But when you come to another donor, I think the problem comes how long can you wait? Most of these patients request transplant like it. So another transplant is initially it will not take exposure to complete one, then we are not I think clearly we check them and it gives a limit to check what offer should be getting basket. Like for finally across the area, check genetics plus also in very offset. Even sometimes it was like a condition, like a hypercholesterolemia. Still they will have cholesterol of 600, and then the disease patient will have other people. So there are certain conditions, so as I said, each condition will be individual. Okay, let's look at the minimum. We go for the domino since they are patient. Yeah, domino transplant, as I said, for conditions like MSUD, we have the anemia, the enzyme is present all over the body, and the liver is not putting the inputs. So that sort of conditions, we know those conditions where we can explain well covered. Just if you want to go auxiliary or not just something like that, just to auxiliary liver transplant is something which we have been doing for metabolic treat, but in acute liver failure, we want to take off the immunosuppression. But in liver, in metabolic disease, we do auxiliary transplant for a couple of reasons. So, it takes away your antibiotic phase, so that there is no decompensation during such event in dialysis.
So one thing place a very disqualified place to release of stability. Again, like during rejection, when your liver function goes down, again liver function per se. While metabolic function can be sort of sorted out using your metabolic diet or whatever it is. So I think these are the two things we are thinking about gene therapy coming up, but I don't know when it's going to come or whether it's going to happen. But I think this helps in this good area. Yeah. Just to add on to this, honestly, as a chronic setting, there is a limited low screen that probably even to avoid the copper. One exception is probably the OTC. What are the OTC one where you don't use whether it's a the they do avoid techniques. They don't Thank you. Thank you. That is Australia. In primary Australia, what is that we are very state level sensitivity. So it's not. I believe primary Australia type 1 and all. You do simultaneously steroid. Yeah. So after that, you check before the steroid for the doctor. For the patient, for the patient, we don't. I think the oscillate as long as the unit the oscillate level will be because like what once they shut down so don't do it necessarily as before the we check the cardiac function to look at all that there so that on that part of the there was one oscillate so the oscillate are trying to do the analysis which has no because the oscillate is a dynamic thing. So once you oscillate, the gain for the solar, you will oscillate for the whole pumps up. So they are using the actual measure of how much oscillating is held. So most of the time, just what you are doing to the system. If it is like sometimes we do have to initial period because initial period they are higher. So initial what they ask. We might be doing that, but I think one way of this is any regards to keeping the gene typing has to be in relations. How the IBAT considered being available. Do you think they will change the management of I think that will change. One of the indications is I cannot going to completely take away. At least 50% of them will have a change. So those 50% will require transplant. Other is available here. In India, it is not available. It's really expensive. Probably farmer they might need to shell out 1.5 lakhs per really expensive. Are you doing any genetic study? Do you have any profiling in Indian patients? There are a lot of studies on profiling. We look at certain types of mutations where biliary diversion can be helpful. They are in type 2 indicated mutation, isn't it? It is for it's only for type 2. And again, I think we look at the cirrhosis and all other things. So it only genetics only contribute 10% of what our decision making process is. 90% is more clinical and what the patient is. I also read this your last year communication about digital post transplant patients. Yeah. For PFIC type 1, we are doing at the time of surgery because we learned over 10 years that actually it helps in decreasing the fatty liver and also diarrhea. Diarrhea can be quite troublesome post transplant in PFSC type 1. So apart from the hepatitis, was it? Yeah, hepatocogenostomy, and the loop will be sort of to the distal ascending colon. That's right. Yeah. Thank you. One more. We use the type 1. Already patient came out on like only something. So we dismantled only that distal end. And then we will learning downwards. Probably proximal. Yeah. I think that's exactly that. Hopefully that patient did not have diarrhea.
Yeah. Okay, we will look at the next video.
Thank you, thank you, thank you.
Thank you. The BC. What's up?
Yes, sir.
So basically, what our panel discussion on donation after cardiac death. I'd like to invite the families. Dr. Liver is a senior consultant in the heart and lung transplant from LDLT. Dr. Ramesh is the director of anesthesia and intensive care. Dr. Manjula is not here. So I'd like to invite Dr. Selva Kumar, who is the chief of liver transplant anesthesia and intensive care at LDLT Hospital, Kolkata. Dr. Yaneshwar, senior consultant in MICU at PGS Healthcare. Yaneshwar. Student time is like thank you. And scientist Dr. Karna will also be joining us. I'm just waiting for so this is actually most, actually all of the donations that happen currently are donations after brain death. So we specify patient is brain dead, and then we proceed for complex clear. So this conversation is the exact opposite. It is about donation after cardiac death. Okay. And this is quite prevalent in US, UK, France, and Spain. I think some countries in this particular area. Now Canada also has a high number of donations after cardiac death, and India is almost non-existent. So our topic is going to be the first thing is I request everyone to put it on. Is this wider in India? That's going to be the first question. And the second question is going to be the logistics and the way it's done. Okay. Yeah. So donation of the cardiac was actually the first type of donation. And only after that, donation after cardiac came. And DCD was initially unsuccessful when it started in the 1970s because there was a high opinion of primary malnutrition and mortality was higher. And then you have DCD, this showed higher, better outcomes. And so the DCD alone, the problem what has happened is there is a mismatch in the supply of organs. So there are huge demand within the supply. And this led to increase in recipient wages mortality, which is what we are currently. So this is two things. One, what is happening is we are accepting more marginal donors older. We have done area and our research and service. When we are that's when we come this topic. So the thing is, brain death happens in only 2% of all deaths as a brain traumatic, which means BCG has a great potential of giving us organs which we are not using. So can we tap this supply? And the number of BCGs worldwide is increasing. So Spain is not okay. Spain is number one. Spain has a opt-out system. What that means is the moment they identify a patient as a potential organ donor, the system goes straight for organ donation unless the family says no. So in India, we have an opt-in system. That is, we go convince the patient's family, this is the potential, do you agree? And then we go, which is a more complex system. Whereas in most of the other countries, especially the top countries that you are seeing on this list, it is an opt-out. So in India, there have been two main centers in Ahmedabad, IKJMC and PGI Chandigarh who have already done DCC. Predominantly, they use KD. And liver has not been published, but Medana has done. And one more center is also that center is also that, which is from the Universal Panel Technology being yes, thank you. So I'd like to start with Dr. Manish. What is the after cardiac or the new terminology HCC might specialize? It's also
I think the new terminology is just release after cardiac determination of death. And we primarily look at the cardiac event as the primary cause of death, rather than compare to say a brain death patient who has a functioning heart death. Now, this, as you correctly pointed out, we have more number of patients who are sick, who are terminally ill, probably have infections which cannot be treated, and they form a bigger pool for potential donors. And it requires a fair amount of planning. Even DDE requires a lot of planning. But then here, we need to start planning much before. We need to interact with the family, talk to them about end-of-life care, withdrawal of life-sustaining treatment. So those things have more importance in a DC or a DCWD scenario. Now, the master classification basically you're looking at controlled and uncontrolled scenarios. So you have the controlled scenarios where you are able to witness a cardiac arrest, the patient is already in intensive care, and we can actually go ahead. This is an anticipated cardiac arrest in a very sick patient. And we can go ahead and plan how to proceed with using this patient as a donor as the family or the patient has given certain instructions. 1, 2, and 5 would fall under the uncontrolled category. 1 and 2 would be basically at the ER, out of hospital arrest, or if we have an unsuccessful resuscitation from the ER. And 5 would be when cardiac arrest in a brain death patient. So we are basically looking at 3 and 4. Sorry, 3 and 4. 4 would be cardiac arrest in a brain death patient. And these are the 2 categories where we can actually have more control and plan for this evaluation.
Yes, thank you, sir. So before we move on, I'd like to invite Dr. Annabelle. Madam is available. Madam is available. Okay. So this is open to your panel. Now we will discuss that category 3 of market classification is going to be the most, that's where we have to start because it is a control. So what is BCD and CECD? What is that? So anyway. So
basically is that you don't have to control, there's suddenly happens, and you convert to the disease. That can be either at home or at the emergency or in the ICU. This can be various vessels. Control settings either in the OT or ICU, preferably in India where we can implement, where we have done a couple of these cities is from ICU, but ideally the biggest challenge for us is how to implement, because the downtime after declaration of the death, because you have a 5 minute notice time and your mom is seeing your time. And it has to be within 40 minutes, the entire process, from the ICU to the reading in 40, relating to the rapid translation, it takes minimum of 1 hour. So, but after the systolic pressure goes below 70, you have to reproduce within 40 minutes to have good results. So, you cannot do practically in ICU. The only way we can do is keep the patient in the OT, wait, allow the attendants to see. And I have said the complete legal process in India, there is no legal thing which stops this from doing. It's just that we are not doing. And you can have a downside, they can contain anything in the OT, see the transplant, then we can start incising, and this easily avoids around 20-25 minutes of time. That's the only way possible where we can do. But majority of Indian DCDs what have been happening are they are actually DVDs, they become a control, they convert to DCDs.
Yes, yes. So sir, what is one of the question is GCD legal in India? Yes, GCD is legal. Is GCD taking place in India? Justice. Is there any data for how many GCD cases are happening in India? So, yes.
I think more important is not whether this is illegal in India, but all of acts of state therapy. It's an illegal acts that it needs to get a lot of hospital acts. You can have that, but that's not to be another happens is about here is one part of the case. Yes, so not to altogether, even in established like the Western countries where BCD is more common, still most of them are type 3 cases. Yes. So in our end, I think the major factor is that we don't have a very clear return of life support guidelines. That is number one. We don't have a lot of basic prevention tests made in the centers where we might be retreating. So actually, if you are going to look at the liver and you want to use a honest meal to present 20-40 minutes, the only option is the other options are maybe down the line. The other factor is pushing and rushing in a setting where we don't have legal clarity, that much of legal clarity in the Western countries will be a bit critical. If you look at the BCD centers, both the major centers are sort of like non-profit government companies. The moment we start going in a private sector, I guess it will be a little bit more tricky and will have maybe the due diligence has to be a little bit more aggressive. So we have to start at directly and then down the line take up other things. So yeah, DC I think to start with we have to in the country and that too with the proper package. Having seen the DCDs in the UK or the biggest is one is the clinical part and how important the organizational capacity of the PVT. Unless you have a very clearly defined structure of the PVT, one is your success rate is low. And a lot of times you don't have a lot of the mechanism of the immediately also look at the emotional aspects of the patients. The whole process clearly defined. It is easy to replicate, but it's not only about the logistic skill set and developing a mechanism of how to replicate, especially when you're working at multi-operating. So everything is sort of now trying to each individually do their own data, especially because of the private industry. So the whole system of working together, the same time people own document planning, all those things have to be in place. Yes, all those things. That will be very, very careful. I think the legal part of other things of PCD, we are not having a clarity on how to take this is happening. Will be to environment, the church,
the liver is the liver is not a problem at all. If it is in house, if it is out of house, it is practically not possible in common centers. It can be possible only in centers with all the facilities. I just want two questions to answer by following. We are thinking, I have a different idea of implementing this thing. Let's do it like you, let's do it in a year. Like we instituted in RP, like learning is a bit more. As soon as the downtime is there, you don't rush, you don't do anything. Just to perfuse the regional organs, put a balloon into the chest, like PJ does, and just perfuse the organ regionally with ECMO or normal regional corporation. You can receive it as elective. How can't we implement that? The cost is involved. The organ is not good, who is going to pay? That clarity has to be there. But other than that, without legal framework, this is clearly possible with the support you can give, the ECMO support you can give. I have thoughts from Morley and
so, honestly, another is like especially the height of your line scalability. But if your question comes that when do we get solution, right? So, point is that the having that five context is should have something is a greatest level. So, if you don't start with that control. If you're not that's the other time doing in the whole thing, that will be nice. You're part of the very yeah. So if you have a protocol like that, maybe at least a discussion point of view, because even if you see something the heart arrested, that no touch can say 5 minutes, and then the time it takes for the examination, position, I have been a few minutes. They can manage the of the time. Not exposed, but we have identified the results pre-operated and what to do. Abdominal organs are the things that will yes, the thoracic organs is a little more complicated. Abdominal organs quickly isolate the upper half circulation and then try to organize it to the capital and then subsequently try and get it. So this is very possible. Okay, so typically is considered criteria, and we have to look at the age, weight, LFTs, and the clinical condition of the ECG model, like hypertension, hypoxia, and cirrhosis. And even ECG recipients have to be selected. We look at the well status, renal dysfunction, and also within the outcome status of the athlete. So this question for the future. Are the outcomes of ECG inferior to APD? So usually when they started in the early 2000s, when we can get existing statistics, transplant. Yes, definitely the ECG was slightly inferior to APDs in certain rounds, especially the part that they go. The lung separately had a similar sort of root comes from practice. Heart and liver had especially given to I think we can have a idea of the revise the criteria for the global selection. And also by introducing the potential techniques like for the delivery and other position techniques. The current they are almost yes, slight increase probably around 10% increase in PDA complications in the liver. But heart, lung, and kidney overall not much difference. Definitely, that's not the donor selection, reduce target information, and also the decision to back out. So one of the diseases, when they practice, they have a decision to back out. That is once you cut off also more than if there is a hypoperfusion for 60 minutes long, and that's still the hardest part of ground background of transplant for certain. Recently, they extended from 150 minutes up to 4 degrees and maybe not the lot. But liver and heart for us in November, if we complete C-section doesn't happen, but there's hypotension for up to 60 minutes. You have a backup and the patient is being grabbed and water out of it. So if you do a proper selection, don't have to current evidence says they are almost perfect. But one of the projects
See, after the advent of testing perfusion, the DCD has been revolutionized. Among 40% of Indian transplants of DCDs, US consults tremendously cut up because of the advent of machine perfusion. Literally every iron is put on the machine of the DCD the next day. The prohibitive complications, at least in liver angiopathy, known as thrombotic strictures, which are very less after the machine perfusion. The main thing is you can check the viability of the liver. If you don't like the liver, you can still reject after the liver or kidney and reject after the perfusion. So nowadays, machine perfused DCD livers are as good as liver livers. And in years to come, this is the biggest revolution in the transplant field.
And also, Dr. Angela Madden, Director of Medical Services, please come and join us on stage for the panel discussion. Welcome.
So I have to what saying. Assessing the liver plays a big role, I guess. What are things we want to do in all the assess like questions like the investors created
So we move on next time. So we have to discuss the recently outcomes of DCD and its consistency almost as good as DBD. So moving on to the other aspects of DCD, risk of management. Why is DCD not grown in India? And what are the implications of aspects?
I think the main reason why CC has not grown, the basically communication and awareness. How, especially from medical centers, from the Selva was saying, we have patients who are spending money, they have bad outcome. They are not, they are not in the frame of mind to actually open it and think about helping out another. So I think the pre-counseling, we should have dedicated nurses for our condition. I don't know if we have that here in the Indian context because it's not it happens very day. And especially if you have a nurse who's able to interact with the family, not just when we need them, but even as soon as we suspect the deterioration or the anticipation, it will go a long way in building rapport with the family. And then hopefully their heart to actually contributing to this business. So I think communication and a proper handholding of the patient's family is very, very important. I think we are lacking in that way. Significant. Yeah, we can do DCD, but I was just discussing about the body. So our current scenario is we many times have a transplant coordinator who does stuff as a recombinant. I don't think that is effective enough. I think that you must have dedicated counselors. You must have somebody who is away from the treating team. Many times, even though we are not supposed to talk about it or approach the topic, we kind of float the idea. We find interest, and then if it's required, we involve the team. I think it should be a parallel pathway.
And I agree with the recently. One of the problems that we have been facing in the past year is that we do not have an immediate counselor. And we have seen that most of the times when we have potential candidate for patient, we are unable to actually take this forward because there's no dedicated for the counseling. Most of the times we have always this rely on this conflict that and the other things they know that he is not the right way. I don't know,
I have a suggestion for you. One of hospitals, never with these NGOs, like one foundation. Becoming employed of the whenever there is a great counseling happening, they will come and they will line up and they will consult and they will come. This has been happening in many hospitals across the country. And Dr. Smith staff was very much willing to help us in this.
Okay, we move on. Next slide. So now into the actual nuts and bolts of basically this from Lisa. How do you actually go on it? What is the mechanism? What is the timeline?
We start with the identification of the patient who is not going to benefit from any further therapy, the counseling, and then the decision will be the counseling the family conflict that you're going to withdraw access to therapy in this patient. So once that's done, a little before that you give a access to and that this is a possibility. I think no one will change the treatment or management or anything like that. But yes, they are all prepared at that point. And this step in between the decision to withdraw to the real withdrawal, I think that's where it has to be meticulously planned. Presence of all the teams, identification where you are going to do, and what all you can possibly do in this withdrawal. This withdrawal, that is decision to withdraw in that video. Like where and strictly at least put the nice regulation on it. That's basically based upon regulations. You go back to the previous slide where you said we know and fast and lot of things. And not sure whether we have clear Indian guidelines which is no there. This all you can do this, you cannot do kind of thing like what you see in international practice from European US guidelines kind of thing. So that this phase has to be planned where all the teams which have obviously reviewed the file internet whenever ready to harvest the organ there. Even once withdrawn of the treatment, like what all your treatment has to be clear. Like whether you're going to extubate the patient or you're just going to disconnect the ventilator and leave the patient there. That's when the then the population becomes significantly affected, hypoxia or hypotension there. That's when your real academic and then one of the patients goes for a cardiac arrest and after the patient takes the standard bed. And once you solidify this, the board has started to get based upon regulation. Indian are not anything that standard most of the places is 5 minutes, but the rating varies from 20 minutes also there. And once the board has said done is that if we clear the head, another the team starts at whatever they are in that particular case. All the information must just open and so that's how it progresses in the basic level.
The complete point I want to stress is there is still one thing I first moment it happens, there is no pressure in the market, then we are putting it on specific times. When you remove it, the next one of the items. Usually DVDs only have one box because the other was significant. In usually this will be significant. So yes, so going through this.
It's looking more product of this one thing. So now the key elements need to have for the so if you have what they say, the clear information in the different one just grab just the condition. So now hospital like this, you are really going to be talking this. You have to really say, but there are a lot of consultations now. Yes, there's you have to basically say. Also, the treatment is low. Also, now this better is for the guidelines. It says you have to be more development. This will add on to what you need to follow the list. This is one of the what they do. What is that? with the itself or transplant itself. Also, that is zero rather than interested in transplant or not. Also, indicated that it must have been fixed. So at the time, nobody is not transplant and then have a outcome. Something very bad on
Time management.
So the importance of annular is every 10 minutes increase of wall stream rate, the chance of ground failure increase from 10% to 25%. Okay, so is there any role of individual procedures against the last? And so so liver and vegetarian.
Basically, it's very big. The start of the time that we have covered the one of the implementation people. There is a role in established contribution and calculation within 7-8 minutes and verbal confusion. Then you do all the dissection after the work. So that's the main difference between the APD and the TCD. I think pretty much sums up the outcomes are same as we told before.
Yes, so research on the and the language is not the missing profession that the language is how the entity impact technology. So this is the data from NHS. It shows the expecting DCD is much better than waiting for a potential candidate to come. And to conclude, this actually very much given us in physics and the whole idea is feasible in India, is it feasible in mass setup? That was the two questions. We can say that the outcomes of the DCD are inferior to maybe, but well selected robots like DCDs will provide comparable outcomes. And couple of those voluntary is key to success. And I think we all agree that type 3, which is controlled DCD, is where we have to start. And we cannot do controlled DCD. Efforts to improve the results in DCD are key. We already have the is correct. And are we ready to admit DCD as a reality for research with automated system? Thank you so much for the back. Thank you. So we move on to the next topic, which is a panel discussion. So the panel discussion special considerations with small babies for liver transplant. I'd like to invite the panelists, Dr. Silva Kumar Kudai, Dr. Gopala Krishnan, Dr. Dinesh Babu, who is the Chief of Transplant Anesthesia and Critical Care here, Dr. Srikanth, and Dr. Somasekhar, Senior Consultant to Denmark.
So, special consideration, small recent liver transplant. I'd like to welcome Dr. Somsekhar, pediatric specialist, Dr. Salman Kumar, pediatric critical care specialist, Dr. Gopal Krishnan, pediatric specialist, Dr. Dinesh Babu, pediatric critical care specialist and hospital specialist, Dr. Srikanth, surgeon. My brief outline will be what you do before, during, after, what are the immediate problems, and what are the least problems, and what are we need to do. So, this is an effective therapy for end-stage liver disease. What is small liver? The liver which are less than 10 kg, but usually less than 18 months or so. So, I first question with Dr. Somsekhar, Dr. Dinesh, and Srikanth, and another. I'll be seeing the different tangents, pathological concern, anesthetic concern, and surgical concern. Before when you plan for the surgery, for that is how it's different from the big disease.
Yeah, small babies are always challenging for intensivist pathologists or surgeons. So just to highlight you, most of these babies when they come to us, they're quite traumatized. They have chronic liver disease, they pay a lot of fat, they have diarrhea, fat loss option and all. So this malnutrition not only affects their length of stay in ICU, but they are not have more outcomes after liver transplantation. So nutrition has to address as soon as we think the child is going to have chronic liver disease. So next, immunization. Most of these babies, there is some sort of vaccine sensitive like immunity. They say, baby is too small, too malnourished. There is we don't want to give you vaccines. They try to postpone it. Especially the live vaccines, if you postpone, you can't give even after LDLT. So the inflammation is susceptible for a lot of infections. Just not preventable infections, but the other infections also. The lesser the age, lesser your immunity. Coming to therapeutics, suppose a less than 5 kilo baby has virus therapy. You have limited options therapeutics. You can't find that. You just have to inject. So people are going away from injecting the viruses, but here we are very constrained. We don't have much to do with our virus therapy. We still next learning. So coming to one unique aspect in small children, if an infant less than 10 kilo baby comes with a hand, we have difficulty in recognizing the clearance. It is always extremely difficult. You don't know whether the baby is crying because of the baby, because of hunger, or it is real trouble in irritability. This is a few things that are not to speak with. You can just stop it with the constraint of time.
Dr. Dinesh and Dr. Srikanth.
As Dr. rightly said, it's very challenging to given it's very people with regards to boundary, because we are able to in regards to new patients, we sort of this based on the English language. Maybe we have 15 to 20%, but the child coming for the transplant, which you can more 15 to 20% higher than the new patient. But in our country, even 20%, they are much less than the patient, which is a point which is quite challenging for us post-operative regions. And like this case, all the things to be considered. And coagulopathy, often very challenging, very hard to see, and that's can be easily managed. Still, it's challenging. And the issues, a lot of circumferences, also the next circumferences, all this stuff will be decided. These are issues which we face in this realistic metabolic complete, for example, PDX, which is not common, but can be a bit of catastrophic loss during this when we use halogen as the reduced. Structural point of view, mainly whereas we are more aware of the small cells per se. But in neonates, especially in infants, like they are currently JK4 leading the way for these large per se. So we generally evaluate the detector volume for the parents or way of the community. So if the GI level comes to more than 4 or something, we are more worried. So if we are operating on neonates, we generally look for a target of GI level somewhere around 2. So we have to reduce the gap. So there are many ways to reduce it. So for that, we have to evaluate that posted diameter of the posted diameter of the abdomen for the baby and all things. And one more important thing, especially in the neonates or implants or whatever, the main problem is the bone weight diameter is very small. And artists is like hardly 0.5 to so that then will cause some problems. So there are different techniques for it and we will be discussing about the so main problem is how to reduce the gap and GWR. Now this is the very important to pay off the evaluation.
So when you are planning, what I would like to add is, as you said, you can even do the 3D printing and see how we can this whether it fits. The three important problems in pediatrics are: one is the size, two is the total weight, and two problems with total weight. Either they are atretic in the biliary atresia or in metabolic diseases, the fluid is going to be part active. So you have to plan for them, especially the metabolic diseases. And the third is the kinking of the total weight, which is a common problem. Arteries are very small, you have to plan whether it's a single artery or a double artery. So these are the most important problems. The other random problems are athletic IVCs, abrasions, big tumors. So there are so many there. So we will move on to the next, what are the things operative issues the next composition to start with. What do you plan for the commission? How do you plan doing surgery for the control?
Generally, they are organized. They have to build up their nutrition. It's not contradictory. Even in fact, if you are parent, we do give corporate to contact per kg of protein. And they are connected, particularly hypotacemia. We need to maintain sodium at least at 135 and hypoglycemia. We are still got these infections. Most of the liver cell parents will have some or other infections. Still, they have metabolic infections. They respond to this one. So these are very common. As such, it's mainly for less than 1 year children. The immunity is still a kind of patient. And the active liver failure or the CLT itself is state of chronic immune suppression. And that will necessarily is having chronic ascites the way proteins, they will go into the pathway. So that's one important area. Another thing is starting from like the systematic way, as Dr. Dinesh correctly mentioned, assess their annual way, like what is easy, the child is bleeding, whether it's anatomical disease, critical social, what adequate is able. And the most important thing is what vascular access we are going to plan, how many access we are going to plan, where we are going to study, this we have to plan. Next is infection control. There is only we can proceed for the surgical assistance.
Let me ask Dr. Dinesh, so how do you approach these babies?
Okay, so I will just summarize what I have discussed. In terms of perioperative anesthetic and anesthetic management, especially. So I think the first part is the disease specific problems, where you can have say something like brain relation with patients, so they can have a particular there's usually any patient will be quite like a second. We have ALL patients, so you will have to manage the the NCP, the CRT, perioperative CRT. So those will be the consideration. If you look at the page mentioned pediatric small baby related issues, number one will be managing the volume of the electrolytes perioperatively. They have probably quite an immature kidneys and they won't take a lot of sodium, no volume food. So we generally stick to the major part of our fluid will be normal copper based on the fibrous management and stuff like that. So that is one thing. And usually we set up a certain amount of fluid parameter, which is another requirement of volume that we to do even before the start of surgery, excluding the blood products. And then anything with blood products, usually we have about 10 of the kg black bags of blood products so that they are easier to give and very release to this stage. IVIS has been discussed. You have an IVD lab, so this is really better to have access to as much as possible. Otherwise, we generally go for up to 300 in a small babies, microcups are very good because when you're having an interaction and increasing blood pressure, you can't have a leaky tracking and all that is quite mysterious. And then if you look at the procedure related things, the major part is like we need to know what's the total blood volume in the baby, how much of blood loss during the decision phase can change things when we want to have blood in hand. The information is predominantly volume related changes in babies. We don't generally see what we have in say something like liver transplant or other tissues. It's predominantly volume. So if you have a volume level, you won't generally see a lot of information. So especially the level is close to 3.5. And then post circulation correlation has to be very considerably managed because they have small vessels. And the last thing we see is when they are closing down how the airway pressures are behaving. Whether there is increase in the down pressure, so that is something that these are the gist of the management related.
Dr. Dinesh, you are an expert in extubation. You will different purpose of the sectors, especially when you handle the amount of small baby. And you tell your experience to the audience and how do you different purpose.
Reason why we started doing this was it's not really so we tend to see the lactate falling from very the reason for it to be the child I think the child is very because of this pressure being negative. Reason if I don't know there is the same critical fluid. One reason the lactates tend to fall more faster. That's the reason why I started getting but not all the time we do experience. We really go seeing what is the lactate. The lactate, if you just know that selling up that one, then to wait for some time of the if there is you go see some bleeding in the child, then you wait and so there are few things really I don't want to explain. For example, like it is associated with cardiac solutions, number solutions. Sometimes we do the cardiac method, they will take it, those children really have a lot of work experience. The only key point is you have to keep your threshold for getting to this very you find this. So the reason why we started exploiting this one is for the pulmonary result. The second is
So, what are the practical challenges in it? As I told, smaller results, high risk of thrombosis, managing, 3D printing. With expect we do monosegmental grafts. Monosegment means just put one segment of liver into the baby. You can have anatomical or anatomical. You can have isolated segment 2 graft, and you can have reduced size from the liver. You make it into a gram piece. You will be literally wondering how such a small piece can be having its own supply. This photograph is just an example of one which we did. It's like 8 kg child, we have structural 2 kg child, children. So 8 kg child, this is the thing in the center is the vascular. They are like 1.2 mm trees. They have to do with high magnification scope. Hemostasis is very critical in small children, especially the blood loss has to be very minimal. And still, would you like to add anything to the surgical challenges like water flow or something? How do you do?
So, especially the patient, normally most people who are like pediatric, so some of these patients now golden embrace, so that it is small portals. So it's left diamond, that's going to be a big challenge because most of the just is going to throw. So what journey we have done next time very honest, is what certain tools is like them I took what they do is they connect like all the collaterals or then primarily go up to the screen of it's a big one place to take jump from there. So that is the most ideal technique, especially in the small population, to increase the portfolio and critical thrombosis cholesterol.
After moving on to surgery, we are going to examine the ICU. I think you through the journey of the baby, how it comes to the hospital, how it goes to the post op, what to expect in the long term. It's an expensive topic. We are just covering the snippets as we have only 4 minutes. I just want to finish the post something in 4 minutes. Dr. Dinesh and Dr. Sarva quickly, what are the 3 important post-transplant considerations?
If you look at specifically small babies, I think as Dinesh was saying, the respiratory reserve and post-op the respiratory physios and the supports, micronasal canal, that will be number one because first they are able to handle very comfortable in terms of chest. And then in the fluid balance, we have especially linings. It's important that we replace the mobility. If there is a poor urination as was discussed before, we can supplement with some parameters in addition to the dental field, something like a test. So those things can help us, especially in patients who have very poor, respiratory muscles and everything. So that can also be done. In the other areas, especially for the post-terminal patients, doing the doctors and checking about the legs and looking for any bowel issues. That's something which we have already, we have really got issues with actually. There is any bowel issues. I think the sensitivity and the checking has to be really aggressive about checking them out because the sports is having a contained perforation or something like bowel emotions. Those are some things which we always miss. And then pain and the sedation, technically, some we do usually better know it, but sometimes I think our television also feels like the patient sometimes requires without an issue where to give morning and all to feel that because
Dr. Dinesh, how do you anticoagulate this? That's a very important aspect of post-transplant management. Start from the surgery.
so these small babies not very good. All the normally we do use currently for pediatrics, we are very little. So we currently anticoagulants. We also use different ACE-based healing algorithm. And also once the child is followed this method, we start the experiment. Let's turn at 2.41 per kg or it was calculated to start the experiment. And also flexing for the initial rescue. That is for the experiment 2 to 3 days. Or a bit molecular verified. Once the child is started, that's all. Thank you,
Yeah. So, Dr. Mohammed, what do you find is two important residual management service post-transplant really.
It's a delicate balance between graft formulation. So what then graft otherwise graft thrombosis. Like you need to always be it should be filled with fluids but though on the overload. Because it's an always a big difference in balance between like when you put more fluids like when you go into graft thrombosis. If it's infection control, we have to start empirical antibiotics and begin antiviral slowly. So antibiotics, antifungal also. So that's the most important thing. So as like our team is doing very nicely, they are moving to in particular children. That place is a very good respirator mechanics so that the positive pressure on the liver and graft is sitting nicely.
So, as your start of time, I would like to ask Dr. Somsekhar, how would you manage these patients in the intermediate and the long form? The nephrologist would actually come here. The early part of the interview takes, then the pediatric nephrologist takes over for the whole life. So, how do you plan these children?
Yeah, there are unique challenges. If you look at baby's immune system behave the right way because it is not mature. In fact, adults they are prone to have more rejections. We don't think so, but they can have more rejections. So they usually need little more higher levels of carbohydrates compared to others. We tend to mention around 7. Comic few children need double or triple or something, also few of them. So then the second aspect is these children have longer time, linear exposure to the immunosuppression compared to others because they have longer expectancy. So this will interfere with their growth, increase the risk of bacterial infection from being like a virus. Especially initially, we are very worried in isolation for the first 6 months to 1 or 2 years. With the highest incidence of being immediately keep monitoring the EME counts. If there is a 1 log or 2 log increase, we can come down and immunosuppression or even give rituximab. On the other hand, persons have non-adherence issues. They feel that I'm well enough, my friend is not taking my should I take the medicine? I very commonly see around 13, 14-year-old child is just stop that. Because well, that's a common problem. I don't want to take. And lastly, neuropsychiatric issues, there is separation anxiety. They think, I'm different from others, I have scar, why should I take medicines, you shouldn't have PTSD. This is often neglected. The child will be trying, we think, this family.
So, after a short of time, we would leave this topic and make it surgical. It's important to follow the couples and further healing complications and bleeding. So, these three we take care. So, this is for centers, there is an excellent 70% of something. So, I think growth and development usually normalize. As Dr. Somsekhar said, lifelong immunosuppression is required. Not just it's complex, but life saving. This is the theme of this topic. How so many people come together to save a child. Most important thing to remember is a child is for a baby is not a small adult. It's completely different. You have to think it's completely different. Early referring to specialized centers is most important. And one of those is surgical technique, effective care, and immunosuppression, and continually improve prognosis. Thank you, Dr. Bangladesh, for the wonderful discussion.
And this guy will come up on Dr. Yama Chandrasekhar. He is a senior consultant in transplant anesthesia and critical care at NGM. And his topic is going to be organ crosstalk, complex interactions in organ liver state. I'd like to call upon the chair for expert comments, Dr. Shields, who is the chief of pathology and lab services at NGM. On stage. Yeah.
Interactions very common and it's not experience. So, why do we need to say this? The most common consideration we see in disease liver, the understanding between interaction between it's not just about the liver, it's the interaction between other systems which are recovered. It's a basic part of cell mechanism beginning the presentations. This pleasure. This moment we are now the images of the content which we will be seeing about what we do, and then that topic about the interaction between individual systems, which we'll be seeing how they impact this is a brief background what we do. We produce color police academy materials transplant, transplants. It's very new. We have been very good. This is the most common clinical presentation when you visit a patient ICU. Complication falls under this. Acid disorders. Other system dysfunctions. Including low cardiac output, liver pattern, sepsis, renal dysfunction. But we are not going to see in this perspective all this because a simple one better is that those thousands of academic papers and also on this now. So when we speak on this topic. This is about what are the events specific to liver disease we see. We have a role of constitution this scenarios, right? And then always online transplanting. Individual renal system measured first total cost plan using conclusions of your full the composition of the protein, all doesn't matter. So, including most people syndrome of the start of the policy. It's all interacts. Let's start with the heart. If you see the heart, is a giving point of all the abnormalities, whether it be functional or structural, with failure, decompensate that failure. We can actually see them, even though they are in failure, but just infection, that is, which we commonly not trace the function of heart. But they still be in failure. The kind of causes not failure, not labor. Not that it is, so the two things that can happen, together in the liver CPS. If it's most of these patients are cardiac transplant, you see something. They have some theory of standard cardiac failure. It can be because of high movement of and because of constant some of it, some relations so these two categories preserve media and the same way reduce media. So that is important. One thing, all of this which we do, it's some functional abnormalities that this is the first child to begin on the hospital. The normal, when you use actual lab, first exposure, they will have included across lab. There's no more prognostic it is scored in all these investigations. So whether these things just identified as whether we don't need it all the time, it's some other plan. So this one, now this, I prefer intro as soon as we start the cases. Typically, identifying patients who will behave, how they will behave during transplantation and how they will behave. It's a simple matter of what we usually observe. Because transplanting one, we see all as in the mobilized organ, the impression of the venous retraction. The normal tendency for the heart, the cardiac rhythm should kick in, the nervous system kick in, that's the right cardiac response of the heart. Blood pressure, all those things should happen. When it is apparent, when you don't see this in the heart, what we do simply do an trial of identity something and look for a response. If there is a response, yes, this patient and some kind of some support is the information. What will do it? If that response is for all support, as expected, in a normal then really definitely at a high risk of their own first cardiovascular disease, most people. So once you identify what are ways to be seeing how we have to back them, you know what happens beyond here is something because we see a group of when they lose the sense of smell, they start going in circles and circles around one another. They kind of go circular, they get exhausted. This is what we call as a spiral of paraffin. I recall the first time that most people need to similar to this camera. Because if you see it in we will be camera. On the own neighborhood solution on the even when the clamp is released, everything enters the right. The second question of one is chemotherapy another composition of the purpose, another all the person entire plant did all the body to the artery. Medical. So when all these things happens together, what happens is that some temporary myocardium is standing around. This myocardium is standing. In the form of decrease in my function cardiac which will be in the monitor state. So the interest of everyone is to target the blood pressure. This gives us hypertension needs to be treated. When you do that, two things happen. This is what we call them as a death spike. Because when you treat that, when all my body is stuck. When you increase the BP, suddenly you are increasing the output, I think she has to function. I think has to bring the output. This time, my doctor is struggling with the facility. After the BP is increased, the afterwards increased. They are going to lose it. So, if you lost it, it requires for that. How many lost it? Once this complex starts up, we have to reload at the time. So, this group thing is more than psychological. I would expect if you take a very standard, most in the cardiac contact with it, I will say the finish of the cardiac. We are finally out. So, what are doing this scenario? So, instead of targeting the BP, what we do is like, directly forget about the BP, just target the cardiac also. We target myocardial infarction. That's why we use T as a grade more than monitors. Arterial questions and we'll see if it is either with the problem. We target the contract. When you target it with contractility, please show the next slide. You can see that this part of the slide. And it shows the relationship between the slow volume cardiac output with the arterial pressures. The left side of it. The left part of it shows that pressure which cardiac pressure which you maintain always an arm. The right side is the shows that decrease in arterial. So what we have is in the during reproduction. You can see when the heart tries to push the blood and start raise after the stroke it can't endure fully. As a decrease in stroke volume, how much it can endure. Which leads to the stroke volume, ejection stroke volume that is reduced. The current of the immediately is reduced. In the same if you see, you rate the afterward, the rate of blood pressure, the ejection of the function of that LDLT equals the volume of this when the ejection system volume is improved, even if this stroke volume and other perspective, in the thing I want to show our active. Whether is not seen of it is the calculated of favorable unit I improve stroke volume. So now moving on to the next, how other impacts the lung. So many details. So liver patient, they will have only the role order unlimited so the evidence the same mechanism is what because I mean it's like this is one thing I want to show off the discussion on this pretty really have those that one by the water is my pulmonary hypertension. Scenario. What you see in the white area is that when during early ejection, one of the pressure, when the volume is ejected, the pressure must be equally up. Whereas in case of body, which is the dotted line, the volume decreases, the pressure stays the same. There is no decrease in volume. Whereas in the severe real pressure, you can see shooting up of pressure, that way increasing the lung is training what happens in the workload is increasing. High protein, dilatation, valve dilatation, all of these things are two things will come out of it. They end up in our failure. Another thing, hepatic venous condition. Overall, this will have effect from development because of function and cardiac everything. So this is basic how each samples are implemented, how all the related. So when we see about exposed related the pulmonary system. Whatever you see secondary prostate effusion mobility over very can reach the CABG 80% the other. This is very commonly you see when you use the air vessels and CABG for the very double digit, like even 30, 35. It's not the mechanical this functionality won't be an issue. When you bring radical stuff on the price, this will not great to operate. This being able for us to know. So this is one of the functional thing, the mechanical cost of respiratory. This is one of the functional the systemic thing we like to see. This is the vital six points. In the corpus, it's on the same time, the surplus. Starts on the vascular and the capillary flow spirit. And the relation behind the substrate, which shows the muscle therapy. At the same time, protein kinase production process. vascular remodeling and to get this phenomenon called and under dead space. So what is under dead space? Scientists don't have that's the appropriation, but they are not getting gas it doesn't have. The same thing in dead space is there is no so only the genetic human recipient. Maybe scientists there's a flow is there, but the extent is not there. So you can't get you have to reduce the flow. You don't need extent is happening. So what happens is we need neutralize as also that's it. The flow is good, it is going to happen. Somebody really connect how the hospital is reduce the because even when the hospital like that, when the action of this, we have a good ventilation. But there is no progression. So even with the platform, there is space areas. It's maximally dilated again into diabetic scenarios. So these are the two which will giving the university service. Moving on to symptoms of hepatic encephalopathy, another one we see commonly this is new. So the first symptoms of the occurring during liver failure exactly. In fact, you have because different mechanics. So the medicine ambulance presentation also varies. One are central retinal, but you have another sensory towards cerebral retinal. So it starts in another discovery system. The GA gut microbes is changing, another gut microbes. With ammonia, the endotoxins are produced, which vascular compartment all the body, the systemic inflammation happens to the mucosal barrier. So what happens is infection, cytotoxin, and other disease you have the ammonia, uremia, all these cycles are in fact. So you can have the situation of hyperammonemia, urinary toxins are there, and the endotoxin. All this cross the blood-brain barrier. Cross the blood-brain barrier. Two mechanisms. One is area. Glutamate pathways are affected. Whereas basic glutamate causes hypertonic situation, cerebrally. Whereas in case of chronic liver disease, it causes abnormal liver transmission. Reactive oxygen species, cytokines, all this inflammation causes other sensory different mechanism for the different support. Another common scenario we see is scenario where overlapping of organ dysfunction or liver disease. Renal dysfunction, AKI, most of these people are muscular diabetes, unlike renal secondary recipients. Now, common situation where muscular damage develop arthritis into the irritability, seizure. Most of them are regulation. What we call the distributing grades syndrome. It can have two mechanisms. One is urinary effort, another is another is still cerebral vasculosis. Because urinary effort is simple. When there is a higher load of urea, it tends to balance it out between the intravascular, intracellular, extracellular, all these three compartments. It is going to integrate. But when you do the dialysis, you want to remove intravascular compartment, urea, urea. You must remove it. Immediately, urea from the extracellular goes to the intravascular. But rapid movement happens running between intravascular and the extracellular. As intracellular urea doesn't move rapidly, it takes time to move out of the intracellular part. When there is a buildup of urea in the intracellular part, osmotic gradient increases and tend to attract fluid into the intracellular. This thing happens when you have the brain. become cellular edema happens. That's why you see. First time hematology in the liver is to actually generate ability, all the things, right? All of those things. So how we avoid it? Basically, fluid, sort duration of trial is fluid, score is 50 to 150 of flow rate. And then this one, the other 137 parts of this big operating, this is true. You cut pH raise process. I know words like the size of pH to the break.
liver transplant one night.
We might know how to say that actually between the current variable system.
Roll ups.
These are three axes which is correcting axis and the green of these parts on the correcting axis. So part of this. This is really good. Either it can be secondary to information during barrier disruption. Basically, very good. Or I need traumatic training. It triggers the operation. What is correcting also the access operation. This is the process. Correct this viruses. Happens once ganglions are development of endotoxins, LDL substances, glucose to the inflammation, barrier disruption, translocation of genetic question. All these things will trigger stress response, which again will very disruptive blood transaction. You have to know that the brain, what it does to the kidney is this European toxin and ecotoxins will suffer so much factor. That is very costly. Media, acute kidney injury, all this combined with the central nervous system. What happens with the nervous system? Renin and this penicillin and this is activated. It leads to water retention. What water retention? All over the products listing is again going to trigger the entire cycle on site. Infection, all those. So below this, all of components are interrelated. These are why we have to have knowledge. It's not just about the liver. You have to bring about your renal function, whatever the access that is affected, needs to be taken at the same time. CNS, take care of the cytoplasm, take care of the inflammatory mediators. How to do this? What we do is we do filters, CRLT filters, oxidation filters, ecotoxic filters. This is not about just remove the excess fluid, optimally correct the electrolytic balance during that conversion. We can also reduce the ecotoxic load. It takes care of entire all these gases. The summarizing what we are seeing. Liver recipients, liver complex are not always just about the liver. It is entire system is involved. Individual cross-trafficking brain, heart, matters how they present, how the treatment response matters. Basic mechanism of how the parts of the brain work. Yes, this one. Thank you. 3 months to really it's a very good comprehensive coverage of all the various organ strengths. So my one simple thing is it might be what I like of it is like sometimes we tend to see where these which is causing this years past So when we like that, the dynamic back on that how it was also pretty balance sort of like cost say like revenue was in those are in
ஆக்சுவலி ஸ்பைக்ஸ் போட்டுட்டு ஒரு பிபிடி அனுப்பிச்சிருந்தாங்க இங்க ஓப்பன் பண்ணா அது முடிஞ்சிச்சு இங்க ஓப்பன் பண்ணா ஓப்பன் ஆகும் பேசிட்டு இருக்காங்க முடிஞ்சிச்சு டைம் வந்துருச்சு பட்
the same with that. But everything is fine. We are not this. The human people we are. But the point is that we need this improvement. We need to constant on the and almost all the places.
Thank you so much. So we'll go on to the next slide. Come on. I made this in academic implications for present and future. Cobra Brewer is the senior consultant gynecology from the whole industry. Welcome to. The chairperson is Dr. Srinath. Over to you.
The massive is regularly associated with cardiovascular disease. The prevalence of the 30 to 40% in adults globally, and it's 70 to 40% in children. Usually, plans associated services is very indicated for the transplant globally. And the overall percentage having so all of the terminology have changed from massive to massive, and what they have included and what they have excluded. So this was the one term, that is non-alcoholic fatty liver disease. Where the best result facts was the percent of the state, overall diversity of liver facts was created by immunity or by histology. They have excluded other causes of liver disease like viral, autoimmune, like excess and technology. Coming to matter. Matter is recommended associated fatty liver disease, where the steatosis is not but any of these three factors, diabetes and cardiometabolic risk factors, are overweight. They have included the all these three major is percent they can be considered as C1. So this may be explain you. Matter they have excluded hepatitis autoimmune systematics, not regret, because there is the diabetes. So that's the matter they can include diabetes. Mostly, the cardiometabolic risk factors in case the individual is lean or wrong. This is the rational criteria for matter. There must be type 2 diabetes or obesity. In case both are not there, the individual is lean or not very, the patients can at least 2 of these cardiometabolic risk factors. This is one is last one because this has slowly evolved from macro to parallel. Macro has included the high components of this cardiometabolic factors, where they have excluded insulin and hyperglycemia. Why the change has occurred? There was a stigma of fatty liver that there was a change in condition. They discovered all fatty transferring, including coexisting alcoholic liver disease as well as other causes of steatotic liver disease. And the conclusion have a unified method which will be practiced with more worldwide so that we can be brought into practice as well as for the clinical research purpose. So, to introduce message is that with the word numbers marriage is a type of liver disease not caused by alcoholism and commonly associated with obesity and diabetes, and they can progress to cirrhosis, which may be a life-threatening condition, so they may produce other life-threatening metabolic problems as well. So, maybe there is a message to from liver upwards, there are no other causes of steatosis. And if there is any cardiometabolic factor in one of this, where they have taken off the insulin resistant and necessary to CRP, leaving the rest of the time, if they have any one, they can be considered as muscle. So these are the landmark years. In 1980, the term NASH was coined, whereas in 2000, lean NASH was described. Lean NASH is nothing but non-alcoholic steatohepatitis individual with normal behavior. Only in 2023, the consensus embarrassed and now national was correct. So, the change in non-measure has happened, but there was 90% overlap with national. So, how do we differentiate between these things? There is usually a review term called mid-area. Mid-area is nothing but metabolic associated liver disease. Coexisting alcoholic liver disease as well. There was a significant overlap between NAFLD and MAFLD. So, they identified that they are subcategories based on the level of alcohol intake is mid-area. With the new entity, there is the definition, epidemiology, clinical profile, we have very limited data And the natural history of the disease process is into this particular. But with the available data, I will tell you about fertility in an upcoming slide. So